can have some discussion. That's why I was requesting if Dr. Sumit could still be there, and you can also request, I think Dr. Sandhya is still there.
Yeah,
So it could be a kind of panel discussion, or it could be a kind of discussion with the other faculty on this theme, that TDM services in resource poor setting. If we consider that ours is actually a resource poor setting, given the fact that if it has been started in 1988 or 89, so 11 years that side and 23 years, 22 years this side, 33 years we are in this. But then how many centers are actually having, how many institutions are having access to TDM services in the country? So given this fact, it is no wonder that there is no denial that there are a lot of barriers, there are huge limitations, and although we may be hopeful that in the next, say, 5 years or 10 years, things will improve substantially, but then we can only hope that. Given this, what could be the possible solution? Or if we say that one possible solution is try to have more and more centers inducted into this. This is one. Of course, as Dr. Sandhya had her comment during her presentation, that to popularize it more, to have more discussion, deliberation, CMEs, conferences, discussions, etc., to motivate younger people to come up in these areas. But then it's not a person's wish, it is also the support that is needed at the institution level. So that becomes also very important, how you are going to convince your institution head. If you are in a government job, then it is not just, most of the government institutions, they do not have enough autonomy, okay, to take this kind of a decision to start a TDM lab. And even if somebody is over enthusiastic and starts it, but then in order to continue with this, the kind of recurring support that you require, and also the kind of teamwork that will be required in a government setting, it's a huge challenge. When I say government setting, maybe the central government institutes are a little better off, but if you think of the state government institutions, okay, it is too much to expect that you would be really very fortunate to start it, and also not just starting, continue with it, really implementing it in the most desired manner to really supplement or optimize the patient care services with the help of these TDM services. So given this, the other strategy could be the centers which are already have established and achieved some degree of success. There are a few success stories in the country, of course, whether it is in PGI Chandigarh or in KEM or in JIPMER or in Vellore. These are the few centers what I can remember. There might be a couple more, but then these are the centers to start with. Whether these centers can also, over and above trying to cater to the need of their own institutions, whether they can also come up with some kind of support, although it may be a little utopian, but then whether as some kind of hand-holding support, these few centers, okay, 4 or 5 centers or 5 or 6 centers, whether they can offer some kind of hand-holding support to some other areas, other institutions which intend to start this. If we can say as a strategy, if at least beyond these 4 centers, there might be another 5 or 7 centers where there is clinical pharmacology training, curricular training program is going on. But even there, we find that they have not yet started for very many reasons. Whether the centers which already have power in a government facility, it's very, very challenging, because to convince your minister or to convince your director of medical education that this is really essential, etc. I am leaving aside the other part, that where from the clinicians, where from they will be sending samples, or they will be convinced that it is needed and it is actually going to add value to their patient care services. This is one part. But whether the clinical pharmacology departments or pharmacology departments, whether they would be able to develop this facility at their center, for that what are the constraints and how we can try to obviate these such constraints in our own setting, in Indian setting. So if keeping that in mind, if we could have some meaningful discussion in the next say 15-20 minutes, that would be great, I suppose. My question was that whether the 4 or 5 centers which have started experiencing this and attained some degree of success, how and to what extent they would be willing to offer some kind of lending hand of support. Dr. Smith.
Dr. Sumit, are you there? Hello? Okay, so I thought he is going to answer this, sir. But unfortunately, I'll have to address your questions. So, I'm a born optimist.
Of course.
So, we have started a program called TDM Education in India. How many of you are aware of it? Only 4 in the hall.
No, but then
you were also there? 5 in the hall.
No, 5 out of how many? So then you will be.
I
is
can
optimistic.
see that's only maybe 10% or 20% maybe.
It's not bad. If you think of the total pharmacology community, it will not come to 10%.
No, sir, I have put my heart, soul, blood, everything into it. So, with the International Association of Therapeutic Drug Monitoring and Toxicology, we have started this program where we are running into the 2nd year now. And unfortunately, let me be very honest, Shambho, you are the leader in this region. I don't see any participation from West Bengal. We have people attending more than 200, 300 from all over India. I am going to, in the Oslo conference, I am going to give them the statistics. We are running a educational webinar series where anybody can join. We disseminate the link on LinkedIn, etc., whatever platform we can. Okay, so one from the West Bengal.
So there is
so why don't you spread the information? Why I want that 1 to grow into 100. So everything starts with practical aspects are there. We don't go away from those realities which sir just pointed out. We have to first make our theory sound, That only will happen when I see participation. Hand holding all 4 or 5 institutions, whoever is doing, everybody is eager to lend their hands. Apart from the logistic bottlenecks, I think there is somewhere our own intrinsic motivation has to come forward.
Right. Actually, I can make a comment here. In our institute, we have been trying for the last 6 to 7 months for starting TDM for antibiotics. In fact, the initiative has come from the infectious disease specialists there. We have started DM infectious disease course there from 1 year. And they have 2 PG assistant professors came from AIIMS. They are trained in AIIMS, New Delhi, and they are insisting us to start this. But as Sir has said, that we have several bottlenecks in the grassroots actually. So we have not reached up to the stage to communicate with you, because we are now striving to assimilate all these instruments and these things.
I completely acknowledge and understand this. I'm not. It's not a blame thing. I mean, I'm just saying that. Everybody has had to give their best.
Right.
And we have several central institutes that have come up. Those central institutes have in their, they're doing the central procurement. They are way ahead of us in terms of procurement of the equipments.
Right.
But I can't see any of them using those equipments to deliver TDM. Bottlenecks are there everywhere. Some of them who have got the auto analyzers, they are doing TDM. I know AIIMS Bhubaneswar is doing, they are giving patient service. I'm sorry, I'm not aware of the other AIIMS, whether they are doing delivering the patient service or not. We all are doing patient service at a very in a very compromised setting. I understand that. Most of it I understand is the lack of intrinsic motivation, apart from the logistic bottlenecks.
No,
can I comment here? Yes, there one can easily say there is lack of motivation, but then again this motivation level also drops down when you find it is both way.
Yeah, hello.
Just wait. I was telling something. Let me complete.
Sorry.
Yeah. We have to think of there are both ways. One is lack of motivation. There is a general lack of motivation. But then again, if somebody is motivated today and then he finds that it is becoming, despite his best effort, it is not being possible at his own institution level to initiate it, to start it, then it goes down. He gets frustrated. So we have to strategize actually. One is, of course, you have to keep on trying to get your facility developed at your own institution level. But if you do not get it easily done, not to get frustrated, and until that is done, whether when I put this across, whether the centers which are optimally successful or primarily successful, whether they can lend support. Lending support could be in raising motivation level, in making people aware, etc., sensitizing them. So one is the educational part. Okay. The other is that in the interim period, when a center X is able to develop these patient care services at their own level, until then, whether some kind of services can be provided by these 5 centers which are right now in the business. I was actually trying to propose that is it possible some kind of samples to be sent. It could be in a very rudimentary level, okay, some kind of dried blood samples, etc. if I try to dispatch you to your center. So whether you are ready to provide some kind of service, it may not be very easily,
so
immediately helping the patient, but
right,
at least to gain, actually to gain interest further, okay. We have to identify some of the areas where even if I get it maybe after say 7 days, it will help in some kind of long-term care situations where TDM has a place, to identify them, and in those cases where this turnaround time is not that too much relevant actually. So we can possibly afford to wait for 3-4 days or 5 or 7 days. Even then, whether there is a need for, there are some situations where you can do that. You just think of the tuberculosis, where we can wait for 7 days. Okay. So think about, if we could think of some of those situations where these 5 centers, they are ready to extend this kind of support. It's not easy to say yes, you will be, because they have their own workload there in their own centers. In order to flourish further, they need to also satisfy their own need. Okay, it may not be so easy, but could we think of doing some kind of like that? That was my question.
Can I give a suggestion, sir?
Yes.
Basically, yes. What you asked is little difficult, but doable for some drugs. For some drugs, for example, TB drugs, it is not stable at all. You may have to do some minimum extraction before you sending it across. But for some drugs, even after extraction or even after you add stabilizing agent, it may not be stable at all. So yes, but there are many drugs which you can send across and we can analyze and give back the reports. That is one thing. But for when we talk about your department, for the department motivation to continue or to prosper or to actually evolve into something bigger, I will have a suggestion. I have a suggestion. This is the suggestion. There are usually in all hospitals there are automated analyzers. So usually it will be in the biochemistry department. So we don't have to set up a lab right now. You already have a lab in the biochemistry lab. So use the automated analyzers in those labs and get the kits like phenytoin, carbamazepine. There are many drugs which you can analyze using those existing automated analyzers. And it's you are not adding any burden on the hospital or on the authorities. So this is just buying kits. So if you start a service, the thing that you need to focus on is not the lab, because you don't have the expertise to manage a lab. What you need to focus is, as a pharmacologist, establish a TDM patient service area. So, for example, that's a place where patient come. It's not unlike a biochemistry test, where the patient goes to a common place and give the blood and go or a pathology place. It's not like that. Pharmacology, you need to get a proper history. So you find a space in your department itself, or if it is close to the clinical area, that will be the best. OP is the best if you get a TDM services board on it.
Got your point. This the auto analyzer services, I think 4-5 years back I also heard, if I am not wrong, AIIMS Bhubaneswar, were they trying that in 3-4 years back, and was it a success story in your case, using auto analyzer and trying to get some trough levels of some anti-epileptics? And so so this could be a success story, and you can also share that with in this forum. Okay, try to exchange that how people have started with little resources, and whatever are the available infrastructure and logistic resources available with us. With that, how we can initiate these kind of activities, and then by this you gain some kind of confidence, and then try to build on that, and gradually try to own a lab which is dedicated for these purposes, patient care service purposes.
Yes. So the sample comes to you, the database belongs to you, you have the full data, and then you actually start service. That's the way you actually progress. So you have some money in your hand to buy equipments of your own.
Right.
So now the focus here, because it's not lab, you can give your entire energy for your use the existing pharmacology knowledge itself. So that way it will be easier and faster for you to convince the hospital management.
Sir, can I add a point on this? Sir, like when it comes to government institutes, like any government institute for that matter, so the first thing, like if we have to help others, probably that institute should get into an MOU, that is at administrative level. So they should get the administrative support, and then even if they send the sample or so, if without a MOU, the administration will be again asking like, how will you spending money on consumables? So that will become an issue. One possible thing is like maybe capacity building can be done. With permission, they can come and learn how to do, what are the simple methods. That is one possibility. And with respect to this auto analyzer, if it is a tabletop, a small portable analyzer, it's okay. Like for example, in our biochemistry, they have a clinical chemistry analyzer which is huge with high throughput. So, like if you want to do some drug analysis using that auto analyzer, where the throughput is very high, for few samples, if you do, it will be like wastage of money and resources. So once we had tried, but then they said, for the amount of patient sample, using that auto analyzer cannot be a good thing. You have to go for a portable one. Okay. So that also we have to keep in mind.
Right. We have our friend from AIIMS Bhubaneswar.
KM, sir. KM, Mumbai.
Achha, KM Mumbai, I'm sorry.
Yeah. I am Dr. Bhaskar. I am working in KM Mumbai. So just like Dr. Sumit suggested, we in KM Mumbai, we already run a TDM OPD. So that is run on Fridays and Saturdays twice a week, and we get referrals from the various departments who send patients to get the TDM done. So where our clinical pharmacology and pharmacology residents, so we only take the history, we fill up the TDM forms, we collect the samples, and we do everything. So this is one very good way to do it, to find a dedicated space, set up an OPD, and provide the TDM services. And with regards to capacity building, we also have a training program. We have a structured training program of 2 weeks, 2 to 3 weeks, wherein people can come to KEM and get trained in how to provide the TDM services, how to set up the lab and everything. Very recently, there was a team from AIIMS Raipur. Dr. Yogendra Keche and 2 lab technicians had come. And from AIIMS Bilaspur also we have received a request. Dr. Meenakshi is the assistant professor there, so she also wants to get trained in that. So yes, we do provide training, and so we can avail of that training services. Of course, we won't be paying for the accommodation, and it will come at a monetary charge, so that thing you will have to bear.
Yes.
Okay. And secondly, regarding the additional provision of services, so of course, so far we have received very less number of samples, as in 2 to 3 samples from other institutes where they don't have TDM facility available, so they have been sending us samples and we have been doing it. So yes, it is practically doable, and how much, that of course we will have to work on a case by case basis, but yes, it is practically doable. We can accept samples from other institutes in the interim period and do provide the services.
Okay, good.
Thank you.
Sir, you have correctly touched the point, because the peripheral institutes are facing the problem of technical expertise for TDM. As he has correctly said, Dr. Bhaskar, that AIIMS Raipur was facing a problem of getting the technician for HPLC. When we got it, then we asked the KEM faculty members, and they have allowed us. For, I think faculty are coming for a week and technicians for 2 to 3 weeks. The expenditure, this TADA will be borne by our own institute. So this technical personnel, it is really a problematic in the peripheral center. We are not getting them. But the KEM, that is a very good help they have provided to the AIIMS Raipur. Sir, I think you remember that Dr. S.K. Garg at our time was not allowing except Naresh to touch the HPLC, because he was of opinion that if multiple persons are handling HPLC, it will not work beyond 1 year. But his HPLC, I think it worked for more than 10 years.
Sir, I am the last student to do the MD thesis, so that worked for 26 years. That was in Waters equipment.
The kind of problem that we mostly face, let us be very frank with it, the center which doesn't have the facility yet and intends to start that, what are the bottlenecks, what are the hurdles? Number one, instrument. So purchasing an instrument. And there are, in government setting, again it has its own procedures for purchase of instrument. If we assume that you have been able to convince the policy makers or your local administrator or whosoever, and you got the funds, even for that, ultimately getting an instrument installed is a challenge, number one. Second is the recurring cost. Who is going to vouch for that recurring cost? Okay, even for the reagents, specimens, etc., everything. Third, technician. Most of the government centers, old persons, they are being as they are retiring, there is no okay, filling the vacancy. Okay, people are now used to put people on contractual service, and getting people on contractual service. Okay. So getting people in contractual service and getting them again trained, that is again another challenge. If you have a technician, then the question of training him comes. You don't have a technician at all. So I'm talking of the real ground scenario in most of the government institutions. Okay. After that, it is the question of convincing your clinicians that they should also be believing that this is going to add value, and for that again capacity building and sensitization, etc., that will be required. So I think in order to really find a solution to these kind of problems that we are facing for decades in fact, and if we really feel that in the coming, we are interested in getting a better picture in the coming 5 years or 10 years, that we have to flag these problem areas and how to obviate them, and then only we can expect that more and more. Otherwise, hopefully there are many new aims are coming. You can say after 5 years there will be 5 or 7 more TDM centers which will be done in the aims only. But if you think of having peripheral centers coming up with TDM facility, if we really want to see that, we have to put our effort and we have to think differently. The PGIs and KEMs are not the representative of most of the hospitals and institutions in the country. That we must admit. Okay. I'm sorry if I am putting a very pessimistic view of this whole scenario, but then that is reality. Let us accept that.
Sir,
if we wish that we need to change things, we have to think differently also. Okay. Please, Dr. Smita.
Yes, sir. I really don't want to end on that, so therefore I have to speak.
Yes, of course.
So, even if I acknowledged that we went through a 2-decade slump after starting. So, I sincerely believe again this intrinsic motivation thing comes. The way we have progressed in last 1 decade only indicates that intrinsic motivation is important. That's the starting point. Of course, rest of the things follow. And of course, CMC Vellore has been one of the institutes, I mean, where I look forward to for inspiration, for technical knowledge, for any kind of analytical trouble that I am facing. So, people are out there very talented, very knowledgeable, very skilled to help, and all we need is a thought and a strong motivation to go forward. And as we know that lot of central institutes have been started in several parts of India. So we have to capitalize on this kind of centers to make them as TDM centers, and possibly making that whole group as single group is important, and that was the vision with which we started the TDM Education in India program, where everybody comes to the same platform. You can ask what are the reagents being used in so and so drug analysis, whether it is useful to do the and continue doing the older anti-epileptic drugs, things like that, where we are trying to look for answers to those questions in our setting. So there is a continuous discussion and brainstorming that is needed, and also the channel of communication should always be open. Whether you are facing logistic, maybe the person who is already some way ahead of you in that line will provide you some sort of, okay, you can contact so and so person, you can write so and so grant, or maybe do so and so thing to get an instrument, or the so and so company provides the kit, things like that.
You have to go beyond this. Yeah.
Right, sir.
To identify sources of sources which can provide resource or can provide the kind of support that is required for developing or initiating your center. But looking at the past, what we find that the institution which have some degree of autonomy in decision making, there it has succeeded, which I find that most of the state government institutes do not have that kind of autonomy. So they have to depend on their local administration or departmental head, etc. I mean the Ministry of Health, state government. There I think it can succeed provided we can give kind of a model where it generate revenue. So those centers which are already succeeded, if you can give us a model, we can try to convince our health secretary that this is a model which is otherwise not only would optimize patient care in certain areas, but it also would generate revenue whereby it can self-sustaining kind of model. If you can give that kind of a working report from your group, from this group, forerunner group, so that might help in developing this kind of center in some state government institutes. Doctor, please, Sanis.
I believe that Shambhu has said that please don't make it too long. So I'll try to keep it short, and I'm going to shift the discussion from TDM in these institutions into something which might also be useful in a bigger way. So many of these departments have now developed capability in pharmacokinetics, analytics. One thing which probably the pharmaceutical industry needs is the ability of people who are trained in pharmacometrics, right? And that will also enable a lot of academic research that is happening in the current times, where you need people who have understanding of clinical pharmacology as well as, you could say, clinical pharmacokinetics. And I'm taking out clinical pharmacokinetics from clinical pharmacology because you need to have analytical hands-on skill to actually do this, right? And this is a big area which nobody has kind of like gone into in many institutions in India. But I think the starting points are there for many of the institutions. So maybe there are some students, bright students, who say that I don't want to go into TDM, and because I feel that I'm not going to stick here, or I'm not going to be the institution. But these can be centers of excellence for pharmacometrics and all these other kind of things which are now the big requirement in the pharmaceutical industry, and even for academic research with new drugs.
Absolutely well said, Dr. Sanish. So, unfortunately, these are two different skill sets. So, a person who does the analytics or does the on-bench analysis, manages a lab, is a wet lab person. And the pharmacometrician is actually a dry lab person who does everything on a computer. So, usually, people are skilled on one side or the other. Usually, one may be having both the kinds of skills. So the best way which I understand is I collaborate with a team. I generate the data. I know that my data is to the best of my knowledge is perfect. And then I collaborate with a pharmacometrician. Having said
Recording in progress.
The teams are important to my mind, so which are coming up definitely in the academic institutions. That's true. It's coming up in the centers.
Thank you.
So I think we can now.
Yeah, with this we will like to thank everybody for the active participation, and there had been a lot of discussion. Please send your feedbacks if you have any on this forum, on the ACPI WhatsApp forum, wherever you feel like. And it is definitely interesting to see that lots of people have lots of thoughts to share, and I actually overshooted the time. Thank you, everyone. Thank you.
So I would like to extend a warm gratitude to all the resource persons for this workshop, especially Sandhya ma'am, Sumit sir, and Smita madam over here, and all the other people who have contributed immensely to the discussion. So we will next move forward to the workshop on drug allergy and desensitization. So for this, I would like to request Professor Sushanta Bandyopadhyay sir to come up here, as he will be acting as the chairperson for this session. And the course directors for this workshop are Dr. Shoibal Mutra sir, and who will also be the moderator for the entire session. I would like to request sir to please come up onto the stage. And I would also request Dr. Taha Ashraf Qureshi, who has come a long way to visit us and participate in this workshop. So he will also be acting as the course director. I would like to extend a warm welcome to both of them to conduct the session. Thank you.
So good afternoon everybody. It's my pleasure that I am amongst all of you. I don't think I need much introduction of myself at this stage. So better continue with the topic for discussion, because every time I experience that whenever in any conference it's very difficult to maintain the time, and that is the most important part. So I'm sure that we are running late. Yes, I can visualize that time was scheduled was 12:30 and now it is 1:30, so just 1 hour, nothing much. Anyhow, so today's workshop is on drug allergy and desensitization. And so without wasting time, I will request our resource person first, Dr. Taha Ashraf Qureshi. Please deliver your deliberation. So I will request all the speakers to maintain it within 15 minutes, because just to maintain the time.
Yes,
please. Thank you. Thank you. Please, Dr. Moitra.
Yeah, thank you. First of all, am I audible, I think? Yeah, first of all, I would like to thank the organizers for inviting me.
Can you hear us?
Yes, sir.
Okay, so am I audible?
Yes, sir, you are audible.
Okay, thank you. So I would like to thank the organizers for inviting me in this ACPICon 2023. So which not much ado, I'll just go directly into the topic. So I will just set the stage so that we can have a discussion on this topic of drug allergy. And would like to have an interactive session, take up the questions, put up some cases and have a discussion, and try to wind up the entire thing in an hour, with definitely touching on the important tenets. If we talk about the drug allergy, which is better to be called a drug hypersensitivity reactions, like how many of you have a drug allergy evaluation set up in your hospital? So is there, just like before, if we can have a poll, raise hand who has a drug allergy evaluation or treatment set up in your hospital? Well, there are 2. Okay. So that shows the thing, that is, we need to have the awareness of this entity. By and large, having an allergy medicine set up in the hospital, it's still in its infancy. Okay. So we recently had a published article, and another article, I think Shambho is also a part of that, where we had submitted it in one of the journal, that what is the status of the allergy practice in India, and that we have pointed out that where are the bottlenecks, where are we standing right now, what do we need to do in the future regarding the training, and to have a specific allergy medicine subspecialty for the training of the medical students. So we are still a long way to go. But notwithstanding in those issues, we definitely need to address the issue of the drug allergy. Better that we say that it's a drug hypersensitivity reactions. We get the patients who come up to our emergency departments with the features of maybe the anaphylaxis, following intake of some drugs, or the patient may come up to any of the doctors saying that he or she has allergy to one of the other drugs. Now this allergy, when we say, or when the patient says, it's very important to understand what the patient is actually mean by this term allergy, which is a very overused and abused terminology. So from the medical parlance, if it's an allergy, it is basically a type 1 immediate hypersensitivity reactions, which we all know. But when we look into the spectrum of the drug allergies, which is better called a drug hypersensitivity reactions, it could be a type 1, it could be type 2, type 3, type 4. It could be immediate, it could be delayed, it could be an IgE mediated, it could be a non-IgE mediated immediate, or it could be using the other antibodies or maybe the other immune cells. So basically the broad term is the drug hypersensitivity reactions. Now it's very, very important for all of us to understand that when a patient comes with a history of a drug hypersensitivity reactions, whether immediate or delayed, we need to find out the culprit drug, because that is the answer which everybody wants. That is number one. Number two is that usually the patient and the physicians alike, they want to know that what drug can be given to this particular patient in the future when the patient needs, for say patient going for any operations, or the patient is going for any other treatment. So whether the patient is likely to react to any of the drugs. That is number two. And number three, what is the likelihood of the patient landing up into a severe hypersensitivity reactions and to some drugs in the future. So these are the three main questions which is very pertinent as far as the patient's treatment is concerned. So what usually a drug allergy clinic or a drug allergy evaluation OPD needs to do is that they needs to answer these questions, and for this they get, usually the allergy department will get a maximum number of the referrals from entire hospitals and also from the other physicians. So keeping this in mind, we'll have a short talk by Dr. Taha Qureshi from Sher-e-Kashmir Institute of Medical Sciences, Srinagar, where he would be talking about in next 20-25 minutes the basics and some of the important tenets in the drug allergy evaluation. Then we'll just discuss that what is the role of the drug allergy testing, how we can test it, and where we should not test it. We'll just briefly discuss about the recent 2022 QuadAI updates regarding the drug allergy. And then we'll talk about the desensitization, in which drugs we should actually go for the desensitization, in which drugs we should not go for the drug desensitization, and what is desensitization and how long it is going to help the individual patient. Then we'll have the Shambho Shamrar Shamazda, who would be talking about some of the cases. He would be showing the cases, and in that cases, we'll just have a group discussions and we'll try to find the answers to how to evaluate and treat those patients. And meanwhile, we can take any questions if you have encountered any of the patients in your practice, in your hospital, in your clinic, and we can discuss those and take up any of the questions which you have. So with this, I'll just request Dr. Taha to come up and just walk us through to his presentations in the next 20-25 minutes. Thank you.
Hello, everybody. I'm Dr. Taha. I work at Srinagar with the Sher-e-Kashmir Institute of Medical Sciences with the allergy division of the Department of Immunology, and recently I've joined the JLM hospital as the allergy consultant. And I will try to be very precise. Soibal sir has made my job very, very easy. So I think I would start from the middle of my presentation. This is not working. Okay, thank you. So I hope I'm audible to the audience online. Am I?
Yes, sir. You're audible.
Thank you. Thank you. So straight away, starting with this, my second slide. How do most patients present? And most of the patients who present as drug allergy, they are already labeled as drug allergy by different people. Sometimes on their own, sometimes different people. So again, my slides are not moving. Can you please help me? My slides are not moving.
Do it from the computer itself.
I'm doing it. Yeah.
You can minimize that.
Okay. So mostly, as Soibal sir said, there are referral cases. There is no proper documentation, unfortunately. Okay, my slides are not moving. Excuse me, can you please help me?
Go to the bottom and there's a you take your cursor there.
So some are labeled by local chemists, some by the nurses, and sometimes children come labeled by their parents, where somebody in the family has been allergic, and the parents assume that the child too would be allergic and deprive them of some very important treatment. And the most unfortunate part is that our fellow colleagues keep on sending patients to us without a proper workup regarding this allergy. They want us to give clearance. They don't want to touch the patient because the patient is already labeled as being supposedly allergic to something or the other, and we need to give clearance to those patients. Now, I'm giving a few prescriptions as a model. You can see vague prescriptions saying drug allergy to multiple drugs. They need clearance for allergy in this patient for different injectable drugs like ceftriaxone, diclofenac, propofol, because this patient was going for cholecystectomy, and asking us to give clearance for these drugs as if they are available on a plate, just like a microbiology culture for the drugs, sensitivity testing. Little knowing that every drug allergy testing costs us at least 1 day and a lot of headache otherwise as well. So then this is another, look at this. This cardiologist has sent a prescription to us. He wants us to give some antibiotic sensitivity testing, not mentioning the antibiotic the patient has to be implanted with a pacemaker, and then for local anesthesia, for radio contrast dyes, vague things, not specifying what all he needs to do. I mean specifically which drug. So then another, look at this. This patient on the right, allergic to all drugs. If somebody is allergic to all drugs, something very kind of impossible. So these kinds of prescription, whenever they come to you, it gets a little difficult. Drug allergy seems to be, a hard task to do. It becomes that HLE is typical. But then, if we try to manage it scientifically, it will become a Herculean strength if you are an allergist. So this patient, 22-year-old male, the new recruit in police department, came to us. He had a grade 3 varicose veins, planned for surgery. He developed anaphylaxis twice. He was sent to us from the department of CVTS. He had anaphylaxis twice with the preoperative drug test dose, Augmentin and then ceftriaxone. Augmentin is the amoxicillin clavulanate, as you must be knowing. Then previous drug history was suggestive of some vertical rashes following intake of some antibiotic for gastroenteritis. So we don't know what the drug was, but it seemed to be something like a multi-drug allergy situation. This patient's surgery was a must because his life was at stake and his job was at stake as well, because he was working in the police department. So we needed to come to some kind of solution in this kind of a patient, and this brings up to the allergist approach to a patient labeled as drug allergy. Before going ahead with that, just a few reassurances that in children, allergies can be outgrown 50% by 5 years and 80% by 10 years. That's a little assuring. Then drug allergies, as I said, they are overreported. Labels are often wrong, 90% of times. Then patients with history of previous documents, of allergy are usually previous docs are unreliable because there is no proper documentation, as I showed you. So skin testing, sometimes people have been skin tested and they have been labeled as positive, especially by non-experts. Well, that's something what's very common in our setup, maybe in the rest of the country as well. They are also usually wrong. Again, a little reassuring. And eventually, only 10% of people who have been labeled as drug allergy worldwide, they prove out to be false. And what is the outcome of these wrong labels? It's so unfortunate. This deprives the patients from taking simple treatments, important medications. Like, imagine the condition of a patient who is labeled as allergic to local anesthesia drug. And I have seen many patients who, because of this wrong label, which ultimately it turns out to be, they undergo even tooth extraction and root canal treatment under a general anesthesia procedure. Imagine the plight, imagine the risk and inconvenience and the cost on the exchequer as well as the patient. Then, unneeded and expensive drugs are given to the patient, especially when it comes to antibiotics. It leads to resistance as well. Cost on the exchequer and cost on the patient's pocket. And the patients develop a fear psychosis. They even, try to avoid treatment sometimes. They become drug phobics, drug cripples. You remember this movie, Diwar? 1972 movie, I think. A hit movie of those times. This movie was based on a wrong label. Mera Baap Chor Hai was written on the hand of this small child, Vijay, Amitabh Bachchan. In fact, Amitabh Bachchan is the great man today because of this movie only. And this wrong label, makes this movie turn into a tragic end, where Amitabh Bachchan, because of this wrong label, becomes not a gangster, in fact, an underworld don, and finally gets killed by the bullet of his own brother, who is an honest policeman. Unfortunately, even very unfortunately, in the lap of his mother, something like this. had this label removed in time or not been wrongly labeled at all, the situation would have been definitely different. So there's a dire need for removing false label in case of this movie and in case of other drugs as well. So what is the allergist expected to do? So rule out this false allergy, and if he confirms the true allergy after testing the patient properly, scientifically, then obviously saying that this is the true allergy and give solutions to it, viable solutions. Maybe a substitute drug or maybe some other way which we'll be discussing. So there are three cardinal elements in this evaluation of the patient for drug allergy. What is that cardinal element? Number one, history. Number two, history. And number three is history. History is the most important part of the allergist evaluation of a patient where he wants to evaluate a drug allergy patient. There's a questionnaire which is adapted. Many questions need to be asked, and this gives you a huge clue about what kind of allergy was it. The phenotype, sometimes patient can have immediate reaction, you can accordingly judge the patient. Sometimes you can have a delayed reaction, and then rest you can evaluate the medical notes, which usually are vague, as I said earlier, and then physical examination can help us at targeted laboratory workup, and finally skin testing is also done to confirm immediate reactions, IgE mediated more so, and apart from this, finally the drug is to be used on the patient, and therefore we challenge the patient with that drug with a definite regimen, and that's called gated drug challenge. We challenge the patient with smaller doses, gradually increasing doses, and that's what it turns out to be finally. That gives an idea that is the patient really allergic to the drug or is the patient not allergic to the drug. And as far as examination goes, there are many ways patient presents. Patient to present as examination gives you these ideas. If patient presents like this, though patient, to an allergist, patient presents in a chronic form only. By the time lesions are settled down, we need to evaluate only. This is the urticaria. Then you can have angioedema. You can have fixed drug eruptions. You can have AGEP, generalized erythematous pustulosis. Then SGST, and these are very difficult conditions to treat. And as far as the laboratory workup goes, there are some parameters which are done and which can give us a clue as to what is the kind of reaction. Serum tryptase is very important among them. It has assumed quite a lot of importance, but unfortunately, because of being costly and because of being less available, this is not employed much. And another disadvantage with serum tryptase is that it is to be done in the first hour of the reaction, and usually we miss that. By the time patient reaches us, those first 1 to 4 hours, some say, they are already gone. So serum tryptase, it has a magic figure 11.4. If it is more than that, it confirms an immediate IgE mediated reaction or an anaphylactoid reaction. If it is less than that, then you can repeat the baseline after 4 to 6 hours and then see if there is a raise of greater than 30%, some say 20%, then it happens to be an anaphylactic reaction or anaphylactoid reaction. So another method of ruling out an IgE mediated reaction is the fluorescent enzyme immunoassay, or the FARDIA as you call it. But this is available for only some drugs, a few drugs only this is available, and in India you hardly get a place where this is done for drugs. There are drugs like penicillin, drugs like papain, and then opioids were done on this, but not much. Then basophil activation test. This offers quite a lot of promise, but it still is in the research area, not commercially available. Same is true about the lymphocyte transformation test. This is used for delayed reaction, but BAT and LTT, they are going to be the future of drug allergy, non-invasive drug allergy testing. Another 5 years or so, this offers quite a lot of promise. Then coming to in vivo tests, skin testing is actually employed. It's very common. Skin prick test, this is also called the percutaneous test. Then the intradermal test, again the test done on the skin. You inject this drug into the dermis part of the skin, and you can see in the diagrams. Then we measure the size of the wheal. Then you have obviously you have to validate this test with a negative and positive control, and then there are different guidelines by which we measure the wheal size, and then accordingly decide whether it's a positive or a negative test. In skin tests, this is being commonly done many centers, but before coming to that mistake, there's another way of doing skin test is doing patch test for the type 4 allergic reactions for contact dermatitis most often. Sometimes for the fixed drug eruptions as well, this can be utilized. We put up a patch, and then after 48 to 72 hours, we read this patch and then find out the reaction and then judge accordingly whether this was positive or this was negative. But this is for type 4 reactions. Coming back to skin testing, this skin prick test or the intradermal testing, the right concentration of the drug used for testing, that's very important, because it so often happens that we use the wrong concentration and then derive a wrong conclusion out of it, usually false positivity out of it. So the right concentration is to be used. These are a few authorities. This is the ENDA, the European Network Drug Allergy Network, and European Academy of Allergy and Clinical Immunology. They have given these correct drug concentrations for the skin prick test and the intradermal testing, and these concentrations are also to be used. Otherwise, if we use the full concentration, that might give us wrong results. This is one authority. There are other American authorities as well. These are the American Academy authorities which have given the concentration of the drug. If we do not use the right concentration, this becomes irritating concentration. We have to use a non-irritating concentration. If we use irritating concentration on the skin, that will obviously irritate the skin, and we will have a huge wheal, we will have a huge erythema, and this false positivity can come up. So correcting the mistakes is the key. For example, this ceftriaxone injection, we often test the patient using full concentration for testing. So lots of false positives, and obviously wrong labeling of the patient. Then the technique has to be correct. You can see on the left, a wrong needle is used, and the wrong technique. The injection is going too deep. It's going subcutaneous. On the right is the right technique. Intradermal technique, the bleb should be raised. The quantity of drug too is very important. The quantity of drug should be 0.02 to 0.05 ml, and not more than that. If we inject more than that, it will again give a false positive result. So pricking too deep, injecting excess volume of drug, these are another mistakes which can happen in drug testing. So we need to correct them. And you see the result of wrong testing on the left side, and then right testing on the right side. Even the marking, you can see on the left, they have marked this, the huge circumference around. And the marking has to be just outside the bleb. And then wait for 15 to 20 minutes in case of intradermal test, and then check out the reading. If that has extended more than 5 mm or more than 4 mm, then only we say that this testing is positive. And obviously after using the correct concentration of the drug, that's where we need to correct ourselves. So that was all true about the IgE-mediated allergy. Skin testing would give us a clue about the IgE-mediated allergy. What about the rest of the allergy? There are many ways patient can have allergies too, or adverse drug reaction to a different whatever drug we test with. So the ultimate belief of whether patient is positive or negative to the drug as regards the adverse drug reaction is the drug challenge, as we earlier said. It's also known as the graded drug provocation test. We start with a very small dose and keep on increasing at the most 3 to 4 steps. And if the patient tolerates them well, obviously we keep intervals in between. We'll come to the procedure later on. But to undergo a graded drug challenge, the patient needs to be fit for this particular test, because it's an invasive test. So these patients should not have any decompensated cardiac illness. Patient should asthma should be under control. If patient is asthmatic, then a baseline blood workup should be normal. Patient should be off antihistamines. Patient should not be on beta blockers, ACE inhibitors, which can prove out to be fatal if there is adrenaline drug, if required, may not work, and for anaphylaxis if at all that happens. And yes, a 4 to 6 week interval from the previous drug reaction is very important, because from the day of reaction up to 4 to 6 weeks, it takes histamine stores to get replenished inside the mast cells. To allow mast cells to have their stores replenished of histamine, then only do this graded drug challenge test. Now, all this is to be done. These drug challenges are to be done under a controlled setup where any untoward reaction can be handled very well. So when we know when to do this drug challenge, we should know when not to do it. Obviously, wherever, in whatever reaction there is an organ involvement, single organ involvement, then not to do it. Or there are severe reactions like severe cutaneous drug reactions like T and SJS and AGEP, etc., etc. And the organ involvement, I told you, nephritis, hepatitis, or hemolytic anemia. Or if the previous reaction was a severe reaction with the drug, it was around, it was 2 to 3 grade anaphylaxis with that drug, never ever do graded challenge with that particular drug. So the procedure, as earlier we discussed, incremental doses are to be given after interval of 15 to 20 minutes each. Some say 30 minutes as well. And the number of steps should not be more than 4, a maximum 4. If the number of steps are more than 4, then that gives a false reassurance to us, because that ends up in desensitizing the patient rather than telling us that the patient is negative to that particular drug. We'll come to that maybe a little later. This is one of the examples of a protocol. You give 10% of the dose first, then wait for 20 minutes. If everything is fine, give 20% of the dose, then wait for 20 minutes, give 30% of the dose, and finally, if everything is hunky-dory, then give 40% of the dose. Dose means the therapeutic dose. For example, amoxicillin is there. 500 is the therapeutic dose. Start with 10%, 50. Then give 20%, give 100, okay? Then give 30%, give 150 accordingly till you reach 500 milligram dose. And the final observation period has to be 1 hour, and if everything is normal by that time, so we interpret the test to be negative. So if there is a negative reaction, patient can consume the drug safely, and we can assume with a great bit of surety that the patient is not allergic to that particular drug. The patient, if labeled allergic to that drug, stands delabeled, and that's a great service. And if the challenge is unsuccessful, if the reaction is positive during any of these steps, we tell the patient not to use this drug, and we provide the patient with an alternative class of the drug. And of course, we educate the patient with the EpiPen training, the adrenaline training. We tell the patient to keep adrenaline, with him or around him quite often, because sometimes, because of the accidental exposure or because of some other reaction by some other related drug, patient might end up having a reaction, and he should have this EpiPen nearby. EpiPen is not available in country, but there is a local jugaad. You can give this, we can discuss that if that comes in the discussion, how to teach patient how to use adrenaline at home or anywhere else if he gets or she gets a reaction. Now, this coming back to our case where this young boy, this needed surgery. What we did in this case, since patient surgery was a must, we selected a preoperative drug from a different class of drugs, levofloxacin. Patient had a reaction with augmentin and ceftriaxone. We thought, let us hope this quinolone would work, because this was idea. I mean, the drug we took this drug, decision of this drug, in consultation with the CVTS department, the operating department, because they had to decide ultimately which antibiotic is to be given or not to be given. So we challenged the patient for this drug, which is the graded challenge for this drug. It was carried out successfully. Patient tolerated the full dose of this. This was the way it was done. This was the concentration for SPT, then intradermal test, and then this oral challenge was done. It all was negative. Patient was operated under Discover uneventfully. So in this case, this in fact we got published as well that time, as it was 2017 as a case report. Then there's another situation, a desperate situation, where patient needs the same drug which the patient has a documented allergy to. Either there has been anaphylaxis in the past, or in your graded drug challenge, you have proven that this patient is allergic to this drug. What to do then? There are many situations, where the patient needs that drug, what a patient is already known to be allergic to, like, iron salts needed in patients where there is, severe iron deficiency anemia, and the patient is proven allergic to iron. Then rituximab in the refractory lymphoma patients. There are patients who have anaphylaxis to rituximab, but they don't have a choice but for that drug. Syphilis in pregnancy, or syphilis otherwise also. So, this somebody allergic to penicillin, needing syphilis so badly. So in that case, this answer lies in something called drug desensitization. What is desensitization? a temporary induction of drug tolerance. This also is called as you tune up the patient with the same drug which patient is allergic to. Start with it with very small dose, keep on giving it in short intervals till patient tolerates the maximum dose of the drug. This is called drug desensitization, and it has different regimens. This procedure, rapid administration of incremental doses of an allergenic drug, just like drug challenge it is, but starting with a very small dose. Even if there's a reaction in between, you treat the reaction, but do it. There are around 12 steps to 16 steps, sometimes 14 steps or something. Actually, it's for different drugs there are different regimens which we have been adopting from time to time. So, how does this drug desensitization work? Actually, nobody knows. These are a few mechanisms which are postulated. Regardless of the mechanism of the drug reaction, whether it's IG mediated, non-IG mediated, desensitization often works. How does it work? There are a few mechanisms which have been postulated, like alteration of expression of receptors, blocking antibodies, then internalization of the receptors on the mast cells, then sometimes activation of the inhibitory receptors. These are postulated mechanisms, but nothing much has been proven as yet. But what is most important is the result, because patient tolerates this drug by virtue of this desensitization. But these all procedures are to be carried out obviously under a very well controlled. After desensitizing the patient to a particular drug, if you want that patient should remain free from allergy from that drug has to be continued for long. You cannot take a break. If you take a break of 48 hours from the last dose, then you want to give that drug again, then you have to desensitize from the beginning all over again. So this often happens in case of patients where you give chemotherapy. You have to give chemotherapy. You desensitize for some chemotherapeutic agent which the patient was previously allergic to, and then after 21 days, after 4 weeks, patient needs that drug again, and in that case you need to desensitize from the very beginning. I mean, start this procedure all over again. But otherwise, for example, somebody is desensitized with aspirin, needing aspirin for a long time. You can carry that on for every day. Don't give a break of more than 48 hours, and the patient tolerates that drug very well. So one of the these are different regimens. I am here showing clarithromycin. You can see it's a 14-step protocol for this clarithromycin desensitization, starting with a very small dose, 0.03 milligram, then doubling the dose every 15 minutes. Then patient keeps on tolerating till patient reaches the maximum dose which needs to be given, 503 milligram in this particular regimen. There are different regimens, different protocols given by different authorities, but the primary principle is the same, almost doubling the dose every 15 minutes, starting with very small dose, 1 by 10,000 of the dose, maximum dose, or sometimes 1 by 1 lakh, sometimes 1 by 1,000 of the dose, depending on the various things like route of the drug, previous reaction, and many other things. So this is the serial dilutions which actually have been adopted for the clarithromycin drug. You take from the stock solution, you take 1 ml, dilute that with 9 ml of the water, it becomes 1:10. Then take out from that second vial 2, take out 1 ml from that, dilute it with another 9 ml of the water, and keep on doing these serial dilutions till you reach the dilution which you want to start with, and then give the dose accordingly. So I would like to share this case of iron allergy with you. This recently, in this year only, we had this 38-year-old female. She was a referral from clinical hematology to us, a severe iron deficiency anemia of hemoglobin 5.6, and she was highly symptomatic. In fact, she had landed into the congestive cardiac failure. Because of this severe anemia, and the underlying cause was obviously menorrhagia, and was planned for hysterectomy, but nobody was ready to touch her till her hemoglobin would be restored, she would be built up. So that's how she landed with us, and this patient did not have history of allergy to any other drug. So 2019 she had an urticaria with iron carboxy polymaldose infusion, though this is supposed to be less allergenic, but she had an urticaria with angioedema with it. 2020 she had urticaria with throat tightening after 1 hour of iron sucrose infusion. Then 2021 she had been given oral iron. She had a doubtful angioedema to that also. Then 2022 she had a grade 3 anaphylaxis with blood transfusion even. So the picture was kind of very horrible, and all these occasions she needed hospital admissions. which is which makes us feel that all the time the reaction she developed was quite severe. So our line of management, we give a triad of oral iron, gastro-friendly iron preparation, but the patient had gastritis, and then she developed some objective symptoms, subjective symptoms as well. So we managed her symptomatically. So the answer, would lie wide, because oral iron the trial failed. She is allergic to every preparation of iron. So where does the solution lie? Can anybody on the audience tell me? Patient is allergic to every form of iron. No iron is patient tolerates. Every iron is allergic in this patient. So what do? You need to build hemoglobin in this patient. Patient does not tolerate blood transfusion even. So obviously the answer lies in iron desensitization. So we took up her, it was 14 February this year only, 12-step protocol was carried out. We took up FCM iron, the iron carboxypolymaltose, supposedly less allergenic, though patient had reaction to this as well. In 14 steps, we desensitized this patient, 12-step protocol. I am presenting this case because, once we did this case, I tried to serve the literature, and this was, to my knowledge, to our knowledge, best knowledge, the first iron desensitization case from our country. So this is, this ICU picture. This dilution, how did we do the dilution? This was, the dilution was 500 milligram per 10 ml. This means 50 milligram per ml, this concentration was there. And actually, yeah, this is how we did it. This is the 12-step protocol. We started with a very low concentration. You can see the concentration over here. We started with 0.02 milligram per ml. The dosage which was available as stock was 10 milligram per ml. Then that 10 milligram per ml we had to dilute. Do see the dilution? We 2 milligram per ml. Make it 2 milligram per ml because this you can. It was the concentration was 50 milligram per ml. This was 500 milligram per 10 ml. That means 50 milligram per ml. Then we had to dilute it up to 2 milligram per ml. 2 milligram per ml. This much quantity we needed for all these. It turned out to be around 250 ml of the diluent, and then make 2 serial dilutions of it. One 0.2 milligram of it, then 0.02 milligram of it. And once we did these dilutions, we started giving it in 12 steps, and fortunately, this whole procedure was uneventful. There's a formula of making these dilutions. I hope all of you are pharmacologists, and you might be knowing this better than me. C1N1, C1V1 is equal to C2V2. C1 is the initial concentration. In this case, it was 50 milligram per ml. Then V1 is the volume. The volume out of that initial concentration you need to take. This is what you need to derive. Rest of the 3 parameters given. C1 is given, C2 is given, V2 is given. What is C2? C2 is the concentration, next concentration needed. The next concentration needed was 2 milligram per ml out of the stock. Then V2 is the volume. Volume of the next concentration we needed was 250 milligram, 250 ml. So we can easily derive this V1 out of this, knowing C1, C2 and V2. C is the concentration, V is the volume. Initial concentration, final concentration, initial volume, final volume. This formula is very easy, and it tells you how to make these concentrations of different agents whenever you need to do this desensitization and make dilutions. So this patient, a 12-step protocol was carried out. The procedure was uneventful. In fact, it took us a whole day. In fact, my resident on that particular day, it was a Valentine's Day, 14 February. I can share you with his status. He was there for the whole day, so his could not meet his Valentine. He wrote my allergic Valentine as his status on WhatsApp. And do I have some time? Present one more case. Okay, shall I stop? Just one case. This case is very close to my heart because this case, in this case, there was a mysterious drug which was responsible for causing drug allergy in this patient. My topic was detection and desensitization. Detection is done by detective, and that's how a drug allergist has to be. 22-year-old female, she was admitted with surgery department of our hospital from 3 days as a case of rectal prolapse. She was planned for surgery after 2 days. Her baseline investigations were normal. But where do we come from? Day 1, she was had generalized rash after receiving IV levofloxacin, and she had no systemic symptoms that time. Day 2 of admission, she had anaphylaxis twice, within 5 minutes after receiving IV dextrose normal saline. The second episode occurred 10 minutes after starting IV Ringer lactate. So, the past history, she had features of allergic rhinitis, she had intermittent asthma, both of them were ignored. There was no history of drug allergy in the past. The patient would tolerate most of the commonly used drugs like antibiotics, NSAIDs, and PPIs, and even local anesthetics. So the culprit drug was to be found. We were called for this only. We were called to be this Sherlock Holmes for this procedure. So was this IV levofloxacin which was causing the problem? Was it IV DNS? Because within 5 minutes of DNS she got a reaction. Or was it IV Ringer lactate what caused problem in this patient? She had a terrible anaphylaxis, remember. Why would it be IV levofloxacin? She has been tolerating most antibiotics in the past. Why would she, this be IV DNS or Ringer lactate? Because these are fluids which are very compatible with our body. So is there something else? So we had to think a little out of box, keep our mind open on this. So we reviewed the history. At admission, just one point out of it, at admission in emergency room, she gave one more episode of generalized rash, shortness of breath, and vomiting just after her physical examination was carried out, which included the perirectal examination as well. So was this the punchline we were looking for? We had a consensus, and surgery on her was deferred by 4 weeks to make her, histamine results replenished and then challenge her. So we planned the unusual this time, not the usual thing. We, at 4 weeks, we tested her with levofloxacin and metronidazole. They were negative. These drugs, because this is what surgery people told us they would be using them at surgery time, then they were negative. Then we did an SPT for latex. This was something very unusual. It was positive. Well, SPT is not be-all and end-all of everything. It could be false positive. We did a specific IG for latex. That again was positive. And finally, to make things very, very clear, we did a puddle test with SPT, with latex, and that again was positive. Puddle test, we prepared a antigen on our own using glove, cuttings from the glove, and that again was positive. So the cat was out of the bag. I mean, the problem was very, before us. We were looking here and there. Mirza Ghalib says that धूल चेहरे पे थी, हम आईना साफ करते रहे. The dust was on my face, but I was cleaning the mirror. How fool of me. The latex was the culprit. So the recommendations we gave were latex-free operating facilities to be used for her, even post-operative facilities as well. So a pre-operative medication regimen as well was, this was suggested, though some authorities don't agree with it, maybe you as well. And the triumph was that the surgical procedure was uneventful, messy with the cup, and we were with this patient's surgery, successful surgery. And later on, the patient's do's and don'ts were counseled for this avoidance in future, and workup for allergy immunotherapy was also taken, taken up. Unfortunately, patient did not turn up later on. She went to Bangalore for studies, and that's how it was. And this paper too got published, as a case report after we did this procedure. And I will not take much time. I have another case, but let it be. So coming to the our experience at SCIM, this is till May 2023. 2017 we started this procedure as a regular feature. We had done more than 350 procedures. Now we have crossed 400. So all challenges for all these drugs we have done, and 34 patients tested positive out of the 351 we had tested till May 34 out of 351. It's not even 10%. So the false labels were again more than 90%. Yeah, 90.3% were false labels, and we have done a number of desensitizations as well, around 40. We have crossed 50 now of late. And this is the world data. You can see Singapore data says 75% labels are wrong. UK says 90 to 95%, and USA data says 90% of labels are wrong. Ours were almost at par with it. I think the story is universal. No blames to our country. So the take-home message is that drug allergies are largely overdiagnosed, mislabeled, and delabeling is badly, badly needed. And what can it do? Reduce cost, antibiotic resistance, and optimize patient outcome. True drug allergies have definitely workable solutions. And for all this, we need an interspecialty coordination. That's the most important part of it. As they say, if you want to go fast, go alone. But if you want to walk far, walk together. Thank you.
So, thank you, Dr. Qureshi, for your excellent presentation.
Yeah, I think Dr. Taha had made excellent presentation on the drug allergy and desensitization. Now we'll take some cases by Dr. Shambhu Shambar Shomasda. Okay, so then we can have some in-house discussion on this.